So let me introduce Dr. Aceves. Dr. Aceves is a professor of pediatrics as well as internal medicine at University of California, San Diego. She truly is a thought leader and innovator in the field of eosinophilic esophagitis. Dr. Aceves has numerous, greater than 100 publications focusing on the pathogenesis of eosinophilic esophagitis and remodeling specifically. She is the discoverer of oral viscous budesonide, as well as participating in studies of other novel antifibrotic agents. She's trained new investigators, is an investigator in the SEEGER consortium, and really is a true innovator and thought leader in this area. Dr. Aceves today will present on treatment of children with eosinophilic esophagitis. Dr. Aceves.
Thank you. It's really a pleasure to be here. You just tell me when Dr. Strawman is hooked back in, and I will stop in my tracks and let him finish. All right, so it really is a pleasure to be here this it's morning for me. Whatever time of day it happens to be for you, I'm very happy to be here and talk to you. You can see my screen okay? Yes?
Yes, perfect.
Okay, so I'm going to talk to you about pharmacotherapy in children that have EOE. So a bit of a parallel to Alex's presentation. And I apologize because I forgot to put in my disclosure slide. So I will tell you that I'm a co-inventor of oral viscous budesonide, and I consult for a number of companies, including Regeneron, which makes dupilumab, which is a little bit relevant to my talk today. So I too am going to start with a clinical case, but in this case, it's going to be a child. And this was a 3-year-old boy who we really did see in our clinic, came in on a food elimination diet, but had a history of failure to thrive, as well as food allergies to peanuts and tree nuts. And so was already avoiding some foods in addition for immediate hypersensitivity reactions. His initial endoscopy and biopsy was done at an outside institution and was reported to show faint concentric rings with pallor and plaques. So for those of you that aren't pediatricians, concentric rings in a 3-year-old is a pretty rare finding. We usually don't see rings in most of our kids. Usually not until teenage years do we start to see changes like that. Histologically, this child had more than 100 eosinophils in the middle, distal, and proximal esophagus, and he had panesophageal fibrosis, which is also rare in a child this age. So we started him on oral viscous budesonide at a dose of 1 milligram a day, and he had resolution of his inflammation and fibrosis. We treat everyone with maintenance therapy these days, and this was no exception to that rule, as Alex had shown you. However, after about 3 years of therapy, the parents decided to stop the budesonide due to concerns of potential effects on his linear height. About 5 months after stopping his therapy, he had an episode of a self-resolving food impaction but continued dysphagia. He came back to us and had an endoscopy that now showed a mid-esophageal stricture that required dilating. He was started again on budesonide at a higher dose, but this time he did not have complete resolution of his inflammation. He continued to require repeated dilation and intermittent prednisone courses in order to control the inflammation that was going on. So due to intermittent non-compliance with his therapy, his esophagus has had intermittent inflammation, but the narrowing no longer requires dilation. So the clinical questions that I think we can address today would be, is this the usual course in children? Could this have been prevented by continued therapy? Because I'm a translational scientist, I can't help myself. I'm going to give you just one mechanism slide on why this might happen in terms of a fibrostenotic esophagus no longer responding to therapy. And in children, how should we really evaluate this potential progression to strictures? So what's the usual clinical course? This was actually the first study done in 2007. It came out of Cincinnati Children's Hospital. It was done by Amal Assad and Mark Rothenberg. They looked at 89 patients, 57 of which had been diagnosed at their center, and then they focused just on those 57 children. Of the 57 kids, 38 had resolution of their eosinophilic esophagitis, but only 8 had no relapse. 30 of the 38 actually had a relapsing course requiring multiple endoscopies. 19 of their 57 patients actually didn't respond to therapy. And that was our first clue that this really was a chronic disease, even in children. So we followed this up in 2019. Kathy Collins and our group evaluated the long-term course of children with EOE. And what we found was that there were 3 distinct patterns of disease resolution. We defined the children as continuous responders, intermittent responders, or non-responders, and that was all based on histology. Children who were continuous responders had less than 15 EOs per high parafield for more than 75% of their follow-up time. This was 146 kids followed for 2 to 13 years with a mean of 5 years. 45% of the children had intermittent response and 15% were non-responders. So when you plot their trajectory on a graph, what you can see is that there are pretty clearly 3 different trajectories. So the continuous responders fall here and they have a nice continuous response. The intermittents kind of jump around a little bit. They're rarely exactly at less than 15. And then the non-responders, well, they just stay with elevated eosinophil counts the whole time. When we asked about the clinical differences using multivariate regression analysis, what we found was that the initial responders had a male-female distribution of 1-to-1. So the usual EOE distribution in most papers is about 3 males to 1 female. They also responded the first time we did anything. So 90% of them had a histologic response no matter what you utilized, elimination diet, topical steroid, or PPI. The intermittent responders had a 4-to-1 ratio of males to females, and they only had about a 49% histologic response. So 50-50 whether they were going to respond the very first time you gave them something. And then within the non-responder group, the male to female ratio was 6-to-1, so a lot more boys than girls, and only a 14% histologic response. And so what that told us was that the likelihood of being a continuous responder seemed to rely on initially having a good response and maybe being a female, which is actually similar to what Alex and his group have seen. When we looked at the endoscopy scores over time, both the continuous responders and the intermittent responders had decreases in the trajectory of their endoscopic features, whereas the non-responders continued to have worsening endoscopic findings. So what about the complications? Is there actually esophageal remodeling in children? So of course, this is something that I think about a lot, but I think it's important that maybe we're all on the same page about what we're going to call esophageal remodeling. And so you can have histologic changes. You can have them in the epithelium. I consider those as basal zone hyperplasia, dilated intercellular spaces, and epithelial desquamation. In the subepithelium, you can have fibrosis like Alex showed you in his slides. Endoscopically, ring strictures, narrowings, in children, furrows can associate with lamina propria fibrosis. And then if you're able to do an endoflip, which is an endoscopic functional lumen imaging probe, and actually gauge the rigidity and compliance and distensibility of the esophagus, you can get a loss of compliance and a loss of distensibility of the esophagus as it starts to remodel. Symptoms of food impactions, dysphagia, and in children, sometimes anorexia and early satiety can associate with histologic fibrosis. So we asked what happens to remodeling over time in children. And so what you're looking at in the left-hand side is a graph of the epithelial remodeling score. So that's a composite index. So in this case, remodeling is being defined histologically. The bottom part are responders. So all of these children had less than 15 EOs per high parafield over time. So this is a mean of about 5 years of time and a total of about 10 years of time. The N in each group is 16 non-responders, 16 responders. So a relatively small N, but a relatively large number of endoscopies and biopsies. So what you can see is if you have response of eosinophilia, your epithelial remodeling stays pretty much controlled. And not surprisingly, your epithelial remodeling, if you're a non-responder, does not get better. So what this tells us is that at least the esophageal remodeling in children can be a reversible histologic feature. If you look at fibrosis, again, the remodeling, the fibrosis in the responder children is significantly lower at all stages, except for the very last one when the N of patients was really quite small as compared to the non-responders, and those are the top line here. So at least in children, histologic fibrosis is a reversible finding. So how about rigidity? This is a study by Drs. Menard Ketcher and Dr. Amanda Muir. So it's a 2-center study, and Glenn was involved in this as well. Dr. Ferruta was involved in this as well. And if you look at children by their age and you look at their diameter, which was a reflection of esophageal distensibility on EndoFlip, what these investigators found was that children who do not have EOE have a wider diameter esophagus throughout all of their ages as compared to children who do have EOE. Amanda and Khalees then went on to ask whether the esophageal diameter could relate to other clinical features. And it turns out that if you have inactive disease, you tend to have a more distensible esophagus. If you have fibrosis, you tend to have a lower distensibility esophagus. If you have a history of stricture, you tend to have a lower distensibility of your esophagus. I can't see my other slides. Let's see here. If you have endoscopic features of fibrostenosis, you tend to have a less distensible esophagus. And if you have dysphagia in the last 30 days, you also tend to have a less distensible esophagus. So this is my one mechanistic slide. Why might this happen? Why could it be that a rigid esophagus no longer responds to therapy when it did initially? What you're looking at here are primary esophageal smooth muscle cells that were isolated from the smooth muscle layers, the muscularis propria of an organ donor. So this was a normal esophagus. And these cells are being cultured on an increasingly rigid matrix going from a Young's modulus of 0.8 to 48 kPa. The cells become increasingly hypertrophic, and if you measure their area, that's significantly different. Their gene expression changes specifically for multiple things, but one protein that's called phospholamban that we happen to be interested in has a metric increase. PLN, if you turn it on in the cell, tends to make that cell bigger on FACS analysis. Interestingly, these smooth muscle cells, when they're cultured on a rigid matrix, will also turn on collagen 1, suggesting that they become more fibrotic. And so it could be that when you go back and treat a fibrostenotic rigid esophagus, that the cells are responding to the rigidity of the environment that they live in and not just to the inflammatory cues that they're seeing. So parents are always worried about the potential side effects of maintenance pharmacotherapy. So we're just starting to learn about this, and I should have told you in the beginning, at least in the US, there's nothing that is FDA approved for EOE, unlike in Europe where you have the formulation that Alex came up with, the orodispersible budesonide. So looking at bone mineral density, Dr. Herman and Dr. Makuta, who are at Cincinnati Children's, did some multivariate modeling, and what they found was that the age at which the child was diagnosed, the presence of an IgE-mediated food allergy or an elimination diet for the treatment of EOE, so manipulating the diet, and any type of PPI use over the child's lifetime, all associated significantly with a lower bone mineral density. So in children, we do need to keep an eye on this since we do often treat them with PPIs and elimination diets. In their cohort, topical steroids did not associate with lower bone mineral density. Dr. Feruta's group and Dr. Atkins looked at adrenal insufficiency. This was a large cohort of children, and they had 5 children that had adrenal insufficiency. What you can see is that children were largely male. They were all on an inhaled version of a topical steroid, which they puffed in their mouth and swallowed. And they all had, except for one child, they had a normal ACTH stim test. So if you pushed their adrenal glands, they actually were able to respond. But again, clinically, especially in children, we want to keep an eye on this. And what I see is that children who are on multiple topical steroids are the ones that tend to have the lowest morning cortisols. Well, what about linear height? That's something we worry about with asthmatics. And Elizabeth Jensen and her group did a study looking at height in children. The only trajectory that was significantly lower was a combination of elemental formula and topical corticosteroids. But you can see these downtrending lines for height by months of treatment in children who were on an elemental diet or children who were on a topical steroid. So again, you want to use a stadiometer and really keep track of the child's height. So how should the potential progression to stenosis be evaluated in children? Because children cannot get endoflips on a regular basis. So is there a way to assess pathologic remodeling? This is a study that's currently in press that Dr. Prerna Williamson did in our group. We looked at compliance in the context of PI1, which is also known as SERPINE1. And our thought process was, can we use a histological stain in the epithelium to get some sort of idea of what's happening in terms of esophageal compliance? What we found when we did this study was that there was a moderately strong correlation that was statistically significant in children. This was an N of 39 between a PI1 stain and proximal compliance. So what that means is that the more PI1 that was expressed in the esophagus, the lower the compliance of the esophagus. We then used the compliance data to make a cutoff, and in our hands, it was 2.6. So if you were greater than 2.6, you were considered to have an abnormal compliance, because your compliance should be, nice and less than 2.6 if it was normal. And then we looked at PI stain, and what we found was that children who had a proximal compliance that was less than 2.6, so I'm sorry, that's the abnormal group, had a higher amount of PI1 staining as compared to children that had a greater than 2.6 value on their compliance measures. So perhaps we can find a measure to use that could be histologic. This needs a lot more validation done in a larger group of children. And I can't say if this would work in an adult population either, but there may be ways to gauge esophageal function indirectly. So what options are there to use when therapy doesn't work? And this is an adult study of dupilumab in patients that were on dupilumab monotherapy. And so dupilumab is an anti-IL-13/4 blocker. And what you can see is that by week 12, there's a drop in the eosinophil count. And there's also an increase in the distensibility of the esophagus. This is a small cohort of patients, and this trial is currently being done also in children. So this slide was supposed to come after you saw Alex's, but you'll see that it's a parallel slide that I pretty much stole from Dr. Strawman and then changed up to be reflective of pediatrics. So this is an algorithm, a treatment algorithm that is based on the AGREE document that came out, which was an international consensus guideline in 2018 in gastroenterology, which basically now says that it is the practitioner's decision whether to use a high-dose acid-blocking medicine, PPI, whether to use topical corticosteroid or an elimination diet. And that all of those therapies can be considered as a first-line induction therapy for EOE. So this is what we do clinically mixed with the AGREE guidelines. So we start an induction treatment based on disease severity and symptoms. So we'll start a swallowed topical steroid at 1 milligram per day if the child happens to be less than 10 years old and less than 5 feet tall, or 2 milligrams a day if the child is older than 10 years old and taller than 5 feet. We'll also do the same thing if the child has dysphagia symptoms, such as food impactions. In children, dysphagia is harder to gauge, but if this is a child that won't swallow their food, they chew and chew and chew, and then they spit it out, we take that to be a dysphagia symptom. If the child comes in and is strictured, we'll sometimes do a prednisone course because we want to capture that inflammation and just get a handle on it. And then we won't do an endoscopy after that, but we'll go ahead and start them on a topical corticosteroid and move forward from there. If the child has largely GERD symptoms or they come to us already started on twice daily acid blocking medicine, PPI, and they're feeling better, then we'll go ahead and keep that going. And then we'll do the next endoscopy on that. We will consider a food elimination diet. We usually will do 4 food. In truth, I try a PPI first if the family is willing to do that, simply because that seems to be a milder phenotype of EOE. And so if you don't have to go through an elimination diet and lots of endoscopies, then I think that that's a reasonable starting point. The next step is always to repeat the endoscopy. If the child is a responder, we tend to just keep the therapy going at the same dose for the corticosteroid. If they're a PPI responsive child, then we'll try and wean the PPI away. If it was an elimination diet, we'll add 1 food back at a time. If they're a non-responder, then we start again with another induction treatment. We'll either increase the dose of the swallowed topical steroid to twice daily, or we'll add an acid blocking medicine, or the opposite. If you were on an acid blocking medicine, we'll either add an elimination diet, or add a topical corticosteroid. And then again, reevaluate. If you're a responder, that's now your maintenance therapy, and you pretty much bump right back to here. If you're a non-responder, then you're going to have to think about something else, whether that's a clinical trial for a biologic, or a course of prednisone if you're really pushed against a wall, or maybe immunotherapy if you feel like this is a very atopic person. So in conclusion, pediatric EOE can be treated with topical steroids or twice daily PPI or an elimination diet. EOE in children is rarely diagnosed with a stricture already in place. Children can have reversal of fibrosis, and EndoFlip also can gauge esophageal distensibility in children, and there may be other markers that we can use as surrogate. I feel pretty strongly that childhood offers a window of opportunity to prevent the complications by using whatever you want to use, but keep that in place and keep following up with that child, because they're not just little adults, and they are going to potentially reverse their complications, and or you're going to prevent the progression. So my talk ends there. Hopefully we can get back to Alex's. I want to thank you all for being here. It's been a real pleasure. We'll be happy to answer any questions. Thanks to Urios and Tigers, and of course my lab and my European and US collaborators.
Thank you, Dr. Aceves, for that outstanding presentation. As usual, you can hear your virtual applause over the airwaves right now. Lots of questions for you. I'll start here. Dr. Hirano asked if the PI1 expression is reversible with treatment.
Yeah, so that's a really good question. So we had a prior study that showed that it was reversible with treatment, and it correlates very strongly with basal zone hyperplasia, and which, of course, as you all know, it can be reversible as well. And so that's probably why it gets better. So it does seem to be reversible in children. I will say that the changes in distensibility in children may be due to that edema, and that may be a much more reversible process than the fibrosis. And I think, you know, with the EndoFlip, we can't really gauge how much is from the, you know, the superficial mucosa and how much is more of a fibrotic or muscular process.
Thank you. So we'll try to get to as many of these as we can. Dr. Mielke asked if the PPI is associated with decreased bone mineral density. Any mechanisms associated with that that you may be able to share?
So what a good question. You know, my obvious answer is that it's known to, you know, leach calcium from the bones. That's a side effect of the PPI. We put our kids on vitamin D and calcium automatically if they're taking a PPI. You know, we don't have DEXA scans, at least at our center, prior to the start of therapy. And so I actually think that there may even be a phenotype of child, perhaps those with connective tissue disorders, that may start with a low bone density and then kind of stay that way. And then as you're aware, Evan Dellin has, and Javier Molina Infante have a study showing, and I think Jim Franciosi has one as well, showing that there can be a genetic component to how you break down PPIs. And so that may be a piece of why some children have reduced bone mineral density. And I think we need a lot more information, but I think, you know, the point is really just keep your eyes open for those side effects, especially in children.
Can you speak to the long-term treatment and dose reduction and follow-up? How do you follow the patients?
So I'd say we need a lot more studies for that. I can only give you my clinical experience, which is that when we stop the topical corticosteroids, for most of the kids, their disease just pops right back. And so we've stopped doing that. Dose reductions in our hands don't seem to work very well. The eosinophils, like you, tend to come back. So as you know from Evan and Alex's work, the eosinophilia can pop back despite compliance, you know, adherence with the therapy. It's just a question of how many are, you know, is bad for you, how many are going to put you at risk for complications. We've tried every other day. That doesn't work for us either. So that's why we tend to just keep you on the dose that works for you. Now, what I will tell you is that our continuous responder group, that was about 65 kids, about 18 of them were off of therapy at their last scope, and 16 of them had continued resolution, and 39% of that 16 were PPI responsive. Now, how long they're going to hold on to that, I don't know, but it makes me want, in my mind, if you're a little girl who responded right away to therapy, it makes me hope that maybe you're going to be able to come off of your therapy as time goes on. But I think we need a lot more data before we can really make those kinds of judgment calls.
And any final comments on surveillance? How do you survey your patients?
Yeah, so we use endoscopy. Dr. Ferruta, we're waiting for your string, so we can use that maybe for surveillance, especially, maybe the kids who change their diet around a lot or have exacerbations during a pollen season or something like that. But right now, it's an endoscopy with a biopsy. That is really the gold standard.
How often?
So it depends, right? We do 8 to 12 weeks if we change your therapy. So if we add a food or take a food away or add a steroid or PPI, 8 to 12 weeks. But if you're doing well, 12 to 18 months, sometimes even 2 years, but we make the kids come back to clinic at least every 6 to 12 months. So we can make sure they're growing, gaining height, not having side effects.
And a final question with a quick answer potentially. If you see fibrosis at the first presentation, do you still consider PPI as an appropriate initial therapy?
It makes me nervous, to be honest.
I
don't know the answer to that one. I personally don't. I tend to want to get rid of that right away, and I tend to use a topical steroid because the response rates seem to be higher. No head-to-head trials, but just comparing study to study across studies seems that we get more bang for our buck with the topical steroid.
Thank you so much for that.